Today, we're going to talk about a study that aimed to modernize and improve our current options for diagnostic testing for valley fever using a simpler and definitely faster lateral flow immunoassay. And as an added bonus, the study was not homo sapien-centric. Welcome to Editors in Conversation. Please subscribe to the podcast and rate or review it, which lets us know how we're doing, but also helps people discover the podcast. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and on Twitter at jclinmicro. Editors in Conversation is supported by the American Society for Microbiology, which publishes JCM. And if you're a member of ASM, you can get up to 50% off of the publication fees when you publish in JCM or any of the ASM journals. I'm your co-host and JCM editor, Ellie Thiel, and I'm joined by my co-host, Dr. Alex McAdam, who is editor-in-chief at JCM and a clinical microbiologist at Boston Children's Hospital. Hey, Alex, how are you doing?
It's been a little bit of a week for me, and we've been talking about this. You and I are both in the middle of big writing projects, and it's been a little bit of a slog for me. How about you?
It's been rough. As you know, one of those situations where you agree to a review a year ago, and then you decide to write it in the 5 days before the deadline. So that's where I'm at.
How's it going? You gonna make it?
Maybe. I'll let you know on the next podcast.
Have you got any tips for people? Any suggestions?
So my tips are probably not going to be very user-friendly, and based on my my experience over the last 5 days, which is basically clear your calendar and write, which is maybe not the most effective way to write. But I know you have some good suggestions.
Well, many years ago, my mother said something to me that I didn't particularly relish at the time, but she said, "You're not a writer, you're an editor." Oh. And she was right. My writing is passable, but I really am more of an editor than a writer. But one trick I do when I'm writing is to have everything open. So that, so I have my Word document open, and I have whatever resources I'm using open, so that when I get a short 15-minute break between one meeting and the next meeting, I can spend those 15 minutes writing. And it's surprising how much you can crank out just by taking advantages of those little pieces of time.
I like it.
I've had a little luck with that this week. Got some stuff done with it.
Yeah, I think I'll take that approach for the next writing project I do, which will not be left to the last minute.
We all say that every time.
I know.
I have to finish this textbook chapter by the end of this month, and it's going to be very tight.
You have a whole month. I have confidence you'll get it done.
This thing is a monster.
Well, today we are joined by two first-time guests who I'm sure never leave things to the last minute. We have Dr. Francisca Grill, who recently completed her PhD in microbiology at Arizona State University. So congratulations, Francisca. And she is currently the Chief Scientific Officer at Cactus Bio, which is a biotech startup company. Francisca, it's great to have you on the podcast today.
Thank you for having me.
And we are also joined by Dr. Tom Griss. Dr. Griss is an associate professor of laboratory medicine and pathology and co-director of the clinical microbiology laboratory at Mayo Clinic in Arizona. So a colleague at Mayo. And Tom, it's nice to have you on the podcast as well.
I'm excited to be here.
Great. So Drs. Grill and Griss, alongside their colleagues, have a paper in press at JCM entitled Development of a Rapid Lateral Flow Assay for Detection of Anti-Coccidioidal Antibodies. And we'll put a link to the paper in the show notes. And yes, for those of you keeping track, this is the second mycology paper in a row that we have done on the podcast. So just throwing in some variety for all of you AST lovers out there.
Ellie, am I correct in thinking that this is the second one you've done in a row that had immunoassays involved by any chance?
No comment, but yes.
Right.
Yes. It can't all be about AST, Alex. So, so we'll jump right in. Francisca, I think it'd be nice to start with a quick refresher on Coccidioides. So can you talk to us about kind of recent updates on the epidemiology of cocci, and then touch on some of the key clinical manifestations we should be thinking about when it comes to valley fever?
Yes, so Coccidioides is the fungus that's responsible for the disease coccidioidomycosis, which you just said is also valley fever, and we commonly abbreviate it to just cocci. And this fungus lives in the soil in dry, arid, and semi-arid environments, which can be found in the southwestern United States. So here in Arizona, where Tom and I are, in Mexico, and areas in Central and South America. Although this makes the disease seem confined to those areas, incidence of valley fever has actually been increasing, and there's evidence of geographic expansion, for example, to the north in Washington state. So valley fever is a rising public health concern. About 40% of individuals infected develop symptoms, which can include shortness of breath, coughing, fatigue, fever, all of which are nonspecific for cocci and can resemble other respiratory illnesses. So that can make it quite challenging to diagnostically distinguish valley fever from other community-acquired pneumonias. So yeah, having it being difficult to diagnose can make it difficult to treat appropriately. And even though the infection is usually self-limiting and treatable with anti-fungal medications, there are a small subset of people who may experience extrathoracic dissemination. So it can go to areas such as your skin, the bone, and even the meninges.
Let's turn towards the diagnostic testing for cocci. Tom, can you tell us how cocci is diagnosed? What assays are people using for diagnostic testing?
Yeah, I like to say that there's sort of a this complete breakfast approach where there's no one assay that gets you there. And a hallmark of disease is a dry cough. So even though culture and PCR can be helpful, if you don't have a sputum specimen to test, you're basically left with serology. There's a couple of tests on the market for EIAs, and then there's the traditional test that Ellie referred to, complement fixation and immunodiffusion, which we send to her lab, which she would love to get rid of those. And we were looking to bring them in, at least immunodiffusion into our lab. But those assays are, it is shocking that we are using these to treat human beings in the year 2023. If you go back and Google telephones of the 1960s, you'll see the technology that we had, 70 years ago. And we've advanced to, cell phones and virtual meetings on our computers and talking watches. And yet we're still using these ridiculously complicated biological assays to detect antibodies to Coccidioides. One of the interesting things is that the antibodies are not protective. So when you see an IgG in someone, it doesn't mean that they have been exposed and are over it. It means they may still have the fungus in their body. And oftentimes when people resolve disease, the antibodies go to undetectable. So this is unlike a lot of the other infectious disease serologic situations that we think of. Ellie could rattle off about 80 others that are the more classic. You get IgM, IgG, IgG sticks around, it's protective. This runs counter to all of that. One of the problems is that antibodies can take at least 2 weeks, often 4 weeks, 8 weeks, even 12 weeks to develop. So when we think about sensitivity, it's not always about the assay itself, but when we're testing. And so we often look at, when we're looking at the assays that we developed, we compare it to other serologic assays. So we're comparing, can we detect antibodies that the other assays can detect? What we really want to know is, can we detect disease, which is a separate question. And so in prior publications, we've proposed a composite clinical reference standard where we're looking at symptoms and radiology and detection of antibodies and looking at the gestalt to make a differentiation of confirmed, highly likely, probable kind of spectrum of disease. And that makes it a little easier to try to figure out, is this telling me what I really want to know, which is, does that person have disease? Because if you compare to a mediocre gold standard, you're going to have a new mediocre test.
Yep. No, it's a good point. And, you bring up the old school tests we perform, and I don't know if people are fully aware of how a complement fixation assay works. I describe it as the magical test, because you have human serum, you have guinea pig complement, you have sensitized sheep red blood cells, and then you mix them together and you look at percent hemolysis, which is all very subjective and challenging and difficult to do. So thanks, Tom, for reviewing that. And, you talked a little bit about molecular testing and the need for invasive sample collection in some cases, and then serology. But I think we'd be remiss if we didn't also touch on antigen detection testing, which is often used for diagnosis of other dimorphic pathogens like histo and blasto, but not typically relied on for cocci. Do you want to talk about why that is?
Yeah, it's just not that great. There's been some publications, and it does have some additive value in the CNS infections. There's a small percentage of cases that will be antigen positive in absence of antibody detection, but for the most part, the additive value is minimal, and standalone, it's not good enough. Mm-hmm. So we don't really use it that much, considering the patient population. Maricopa County, which is where Phoenix area is the highest per capita incidence of Coccidioides in the world.
Yeah, I think that says a lot.
Yeah, I mean, 10 to 30% of community-acquired pneumonia is valley fever. 10
Wow.
to 30%. So when you think about the area of like La Crosse, Wisconsin, eastern Minnesota, or areas of East Coast like Connecticut, those Lyme hotbeds, that's what it's like here, but for these fungus.
Yeah.
Francisco, we've heard about the available assays, and it sounds like they have a lot of limitations. So let's start to talk about your paper. Can you tell us about the assay that you developed and take us through how the assay works, and then the goal of the study as well?
Yeah, so as Tom and Ellie were just talking about, the tests we use now are quite outdated. And we really want to make a better one that's, more modern, more accurate. And even though the goal is to detect the disease, as Tom said, and not the antibody response, that's been quite difficult to achieve. So the focus of this study was to take what we currently have available to us, which is this panel, I guess, of antibody tests, and improve the speed and accuracy of them. The test we developed is specifically looking for antibodies against one protein called chitinase 1, or CTS1, in an LFA format, which is lateral flow assay. And CTS1 isn't, a protein we pulled out of thin air. It's used interchangeably with the term CF antigen, which is complement fixation antigen, which was named so because it was used in that test before anyone knew what CTS1 was. But since that, CTS1 has been identified as a main seroreactive component in those antigens. And although we're not the first group to investigate this antigen, its importance in valley fever diagnostics is well documented in the literature. So it seemed very past due to develop a modern fast test that utilizes this antigen specifically.
Yeah, and I thought one of the interesting things about your study, which we don't see too often in JCM, is that you designed it for use in humans as well as in a variety of animals. So can you talk to us about how you designed it so that you could detect these cross-species antibodies?
Yeah, I think it's so interesting, too, that we were able to do that, because when you think of a typical immunoassay design, antibodies are usually detected with a species-specific secondary antibody. So, for example, in the Coccidioides EIA, there's an anti-human IgG or IgM antibody that's used. But when I personally started out in the valley fever diagnostic world, I was using immunodiffusion assays, which you can test any species in. And that's because immunodiffusion looks for the complex of antigen with antibodies, regardless of what the antigen is, who the antibodies came from, or what type of antibodies they are. So our assays kind of modeled from that, where we're capturing the complex of antibodies to CTS1 at the test line, rather than identifying just an antibody singularly. And so doing that allows the assay to be used, as far as we know, with any species that makes antibodies against this protein.
Yeah, it was really fortunate that we had Francisca join our lab. So when I say our lab, it's Dr. Doug Lake and I from, he's at Arizona State University, and he and I have worked together for over 12 years on trying to develop better diagnostic approaches. Our main goal is an antigen assay, ultimately, that works really well. But along the way, we've developed some really good serologic tools. And when Francisca joined the lab, she came from a veterinary testing lab. And as she mentioned, she had done a lot of immunodiffusion. So great skill set to bring in,
Yeah.
And in this area, I mean, if you have lungs, you can get valley fever. So this includes marine mammals, zoo animals, you name it. If there's lungs, there can be cocci there. So there is a veterinary need in this area for sure.
Yeah.
Good.
So
and we'll have to come back to some of those. I'm sorry, Ellie. Go ahead.
No, I was going to just underscore that the key is that we're detecting a complex rather than simply antibodies, which is what most of the other assays are developed to detect.
Correct.
Very cool. Tom, there is another lateral flow assay out there already that has FDA clearance for detection of cocci antibodies. Tell us how that assay compares to your assay, in particular the design of the two tests.
Yeah, so there's a couple of differences. One is the format. Theirs is a bare strip that you put into a tube and it just kind of absorbs and runs. Ours is in a cartridge, kind of like a lot of those COVID over-the-counter tests you might have seen. So there's that form factor. Theirs takes 30 to 60 minutes until you can read it. Ours runs at 10. And then the antigen that is used as bait for antibodies, as is true for a lot of vended products, we don't know what's in there. We know what ours is, but there's probably a milieu of proteins. So there can be some, perhaps lot-to-lot variation. We don't know what species or if there's what kind of preparation there was. If you look back in the literature for Coccidioides, you'll see there's different types of antigen preps that have been used for different things over the years. So it's likely one of those preps, but we don't know if this is one of the type strains or a collection of strains. And then ultimately, that will have impact on how the band looks and the performance.
Mm-hmm. Mm-hmm. Thanks, Tom. So, Francisca, can you kind of take us through your study design and talk about what samples you used, as well as what your comparator methods were when evaluating the new LFA?
Yeah, so thanks to Tom and our collaboration with the Mayo Clinic, we have this wonderful source of samples to test from people who have their blood sent for cocci-related testing. And as I said, those are the human samples we use. The non-human samples came from a variety of sources that are talked about in the paper, and those included canine, macaque, and dolphin samples. And those came after we had already completed our ELISA and LFA data set with the human samples. And when we saw how awesome the results looked for the human side, we were excited to reach out to any collaborator that we had been in contact with for other things, or in some cases, they were referred to us. And that allowed us to validate the tests beyond the human world. The comparator method we used for both human and non-human samples was against the available diagnostic information, so strictly comparing diagnostic to diagnostic. In the case of animals, it's super straightforward because they mostly just use immunodiffusion, so that was easier. And then for humans, it's more complicated because, as we talked about earlier, there's the EIA result, which gives an IgG and IgM. There's the immunodiffusion result, which also gives an IgG, IgM result. and then the complement fixation result. So I think I calculated it, and it's like 32 possible diagnostic profiles for one person based on the combination of results you can get. So to be as transparent as possible, we compared our assay in multiple ways against a combination of those assays. So no assay on its own, because no assay on its own is completely representative of the clinical picture.
Gotcha. When I was looking your paper over, I thought it was interesting that you started by creating an anti-CTS1 ELISA. Francisca, can you talk about why you did that and what you used that assay for?
Yeah, so for the first part of the study, we wanted to show that detecting antibodies to a single protein, in our case CTS1, was in fact appropriate. And so we tested them by a straightforward indirect ELISA, where we did use a species-specific secondary. And we're not the first group to do this, so you can find more of that in the literature. But we felt it was important to corroborate previously published results with the samples we were using. And so by doing so, we established further that CTS1 is in fact an important protein. And actually all the human patients in our data set, except for one who had a positive ID and CF result, also made antibodies to just CTS1. So that was just important to do, because a lot of people ask, like, just one protein, really? But again, there's that kind of mix of diagnostic profiles people can have. So if we look at a patient who was positive by either CF or ID or both, the number's still high. It's not 99% anymore, but it's 93.3%. So we can't say every single person makes detectable IgG against CTS1 by this ELISA, but a majority certainly do.
Mm. So one of the challenges with CFID testing, and CF in particular, is that you get these CF-only positives. And what do you do with those, especially if they're low? So you had a number of CF-only positive samples that were negative by your ELISA. And so I was kind of wondering if you looked at the titers of those samples, of those discordant samples, to see if they were all on the low end. Because one of the challenges we have is you have a CF only of 1 to 2 or 1 to 4. What does that mean? Probably one of the most common questions we get.
Yes, and I definitely looked at those because I've asked that question too. And it was such a divide, because out of those 12 patients that were positive by CF but negative by ID, 6 of them, so half exactly, was below our ELISA cutoff, suggesting that we didn't detect IgG antibodies to CTS1. And unfortunately, from just looking at their diagnostic profile, nothing stood out that divided the group of 12. You are right that they had lower CF titers. So I think 5 of them had a 1 to 4 or lower, and there was one that had a 1 to 8. But we were able to pick up plenty of individuals who had a CF titer at that level, but were also positive on ID. So from a diagnostic profile alone, I can't explain the divide, and we'd probably have to do a chart review to kind of determine their valley fever status, if you will, if they were, recovering on treatment. So just diagnostic to diagnostic, I can't tell you.
Yeah, those are the tough ones. I think a lot of them are probably false positive, or maybe true positive, but not clinically significant. And that's maybe what the EIA is trending with. So it was interesting to see. Thanks, Francisca. So Tom, from your ELISA studies, you, again, essentially confirmed that the CTS1 antigen is a good target for Cocci IgG antibody detection. And so you took that and ran with it and developed your LFA. So can you tell us how the LFA performed in human samples specifically?
Yeah, it was something we were curious about, because after her initial EIA work, it seemed quite promising. And when you think about it, especially your laboratory in particular, we've seen this before with some other diseases where Lyme, going from a lysate to 1 or 2 antigens. EBV, we name those antigens. So there's certainly precedence for looking for one particular antigen that might be immunodominant for whatever reason. And that might be part of why we get good specificity. Now, the other part of that is positive and negative predictive value depend on prevalence. And rather than like a seasonal prevalence, like you might have for Lyme or influenza, we have a geographic prevalence. So a positive result in Maricopa County is much more likely to be real than in Rochester, Minnesota. And part of that depends on exposure history and things like that. But for the most part, our studies are going to favor specificity because there's so much around. So when we looked at this with characterized specimens, we were surprised to see actually how well it did. It had very good comparison to the established traditional methods.
Tell us a little more about the performance in humans. What was the sensitivity? What was the specificity? Park.
Yeah. I'll have to reference it. We have a lot of different numbers in there, so I don't want to misspeak. But if we look at agreement with the CFNID, and this is positive predictive agreement of 94 of them that we tested, it agreed. There's 100% positive predictive agreement. And if we look at CF and or ID, 93%. And specificity looked quite good as well. And we found that even with the assays that are FDA, but using other lysates that might, because of their milieu of antigens, that might pick up other antibodies, the specificity of for instance, we use the Meridian EIA in our laboratory routinely for the in-house EIA, and its specificity is quite good. And some people might find that surprising. But part of that is in a manual assay, you have to make sure you're washing it really well. So there was a partial inflated bump in positivity a few years back in our area because some of the labs weren't washing their plates as well as they should for the IgM in particular. So they were picking up some low-level cross-reactivity. But I think, again, when we're focused primarily on detecting the IgG, that probably favors our specificity as well.
So that was the performance in the human samples. And as we've talked about, you also had some animal samples as well. How did the assay do there?
On the animals, again, it was surprisingly good. We get limited history of them. They're Bailey was positive or whatever by other methods, and we don't always know what the reference method was, if that went to a veterinary lab or if that was an in-house method or whatever. But it did very well, and you'll probably ask about the intensity of that band, and I think that was surprisingly favorable also, which went along with the human data. So we're kind of all lumped in with mammals, and it performed well against all mammal samples.
Francisco, one of the benefits of the complement fixation assay is the ability to monitor the sort of semi-quantitative titers. Was your assay, your lateral flow assay, quantitative in any way? And if so, how did it correlate to those complement fixation titers?
Yeah, I can't remember now if Tom mentioned a difference between our assay and the currently available one, but ours is semi-quantitative. We can quantify the density of the test band using a LFA reader. And we did, so I guess those are density units, they're kind of arbitrary, but we did see a correlation between the value of the density units where patients who were higher in their CF titer had higher densitometry readings. And I wouldn't say there were discrete bins, but just like with a CF titer, I definitely think that if we were to say, between this range and this range of density unit values, they correspond with this range to this range of CF titers. And this was true for the animal samples too, but the data set was much smaller. So I think we need to test more samples, especially longitudinally from the same patients, because then we can further investigate the relationship between densitometry readings and disease course.
Right. Thank you. And I think that's maybe something that wasn't made as clear is that when you're reading this particular LFA, it's not by eye, but it is by using a more objective, potentially more accurate densitometry reader, which I think is definitely a bonus. So Tom, you compared, so, you looked at performance relative to currently, classic assays, but you also looked at your LFA versus the currently commercially available LFA that's on the market. So I'm wondering if you can kind of talk about how they compared head to head.
Yeah. So we wanted to know, versus the only other thing like it out there, how did it do? And ours was more sensitive. And as you go through the different, we didn't look at all 32, like Francisco said, but when you look at the different comparison to the other assays, ours performed favorably at every level down there. And there was some higher titer ones that the other assay missed, which was a little surprising. There, like Francisco said, I think we missed one that was like 1 to 8. We might have missed one culture positive. So there's really no perfect method out there. But in terms of, can we get away with running one assay instead of 3?
Mm.
And can we get that today instead of waiting 4 days to send it to your lab and get that result back? I think there is, we're showing promise that we're getting to that point. When I first came to Mayo Clinic, Arizona, I was trying to take in all these different mediocre tools and figure out how to advise the practice. And there are papers showing for immunocompromised patients and different types of immunocompromised, there's different levels of positivity. So if you have solid organ or HIV or other type of immunosuppression, they can have differential positivity with EIA versus ID versus CF. And when we have such a high population of immunocompromised at our site, we do more solid organ transplants at our campus than anywhere else in the country. So when we have that many immunocompromised, we don't really want to miss this because it can have implications for pre-transplant screening or once they start on their immunosuppression. So I would advise doing all 3 tests, EIA and ID and CF. What we're finding doing some retrospective look backs now is that the additive value of doing the ID and CF is probably pretty minimal, especially if you're going to test a couple weeks later. If a patient looks like they have valley fever and they're negative, you can test in a couple of weeks and maybe they seroconvert then. The EIA tends to be positive first ahead of the others. They're all useful.
Mm-hmm.
But if we can replace all of those with one test, that simplifies things for everybody. And you mentioned the reader is really nice because it gives it an objective score, and we can validate what that cutoff should be or define an intermediate zone for the ones that are like, I kind of see it there, but is it intense enough? But just to be clear, it is a visible line. It's not like one of those fluorescent bands that you can't see. So people could use it as a pos neg and do pretty well off a scorecard that comes with it, where you have a minimal level of intensity. But it was really, to me, surprising that we could get such a correlation to titers, especially up from 1 to 2 to 128. When you think about that dilution series, to have that dynamic range in a band was pretty impressive.
Yeah, that's pretty cool. So Francisco, one of the key differences between the LFA and the currently used EIA, ID, CF combination of assays is that you're using, again, a single recombinant antigen versus other methods which utilize culture extracts or multiple different antigen preparations. So what are some of the limitations? We talked about the advantages, but what are some of the limitations of this sort of single antigen diagnostic approach?
Well, one limitation that might be kind of obvious is by looking at one antigen, there's the potential to miss antibodies that are made to a different antigen. But as far as I know from the literature and the data we've published, that CTS1 is a great antigen target. But yeah, it might not be all encompassing. And also, CTS1 is associated with the antigen preparation that's used to detect specifically IgG, which follows an IgM response. So CTS1 antibodies are not typically associated with detection of, just a few days post breathing in arthrochonidia disease. So it is possible that by just using one antigen, we're detecting patients at a certain point in time. But I don't necessarily see this as a weakness because if we look at the EIA, for example, even though some people are picked up really early with an IgM, and there's lots of literature published about how valuable that is. There's also been a high false positive rate associated with that. And I don't know if I want to speculate, but I almost want to speculate that maybe the inclusion of the IgM antigen on the other LFA out there, they say that they stripe both CF and TP antigens on that strip. I think that might contribute a little bit to cross-reactivity of the assay with similar fungal infections like histoplasma. I think in their insert, they say it has an 80% cross-reactivity. So I can't say that for certain, but I don't necessarily see detecting this protein alone as a main limitation. But also, I guess we don't really know the relationship between antibodies against just CTS1 and disease status, because currently all assays use a mix of antigens. So that CF titer that's being reported is not just antibodies against CTS1. So again, I think monitoring patients longitudinally for specifically CTS1 antibodies can kind of help us understand that relationship more and really figure out if that is a limitation or beneficial in any way.
Sure. Yep. So sounds like some future studies to be done.
Yes, much needed.
Speaking of future studies, Tom, this was all on serum, right? So are you looking at other sample types, anything that might be easier to handle at point of care, for example?
Yeah, we are looking at a formulation that would be just as the same performance for finger stick. And if you're familiar with LFAs, that involves putting in a blood filter and, kind of accommodating a little higher volume, but a little more in the way of clotting factors. And so it's another added layer of complexity to setting up this type of test, but it is something that we're working on because obviously that would be very beneficial to room a patient, do a 10-minute test, and then have that conversation today about, you have this disease or your treatment is not working, or are you even taking that fluconazole? Your liver enzymes are fine, so it looks like maybe you're not taking it. But people have some side effects to the standard empiric therapy, fluconazole, and they can have dry skin, they can have brittle nails, and lose a little hair, and that's not something that most people look forward to. And if you're taking this for months, compliance or adherence really can be a factor. So there sometimes that will instigate a change to a different therapy. But overall, none of the therapies are cidal; they're all static. And I should really preface this by saying, in Arizona, the going approach is that if you're otherwise healthy and normal and have symptomatic valley fever, you don't require treatment. We don't have evidence that it really helps in a healthy, normal person.
Thanks, Tom. So Francisco, since one of your goals is to have this assay available for veterinary purposes as well, I'm curious if you've shared these findings with your local vets, your local vet clinic, to kind of get their input on whether implementation of this sort of assay would be of interest. And then I'm also curious, have you looked at some of the associated requirements for, validation of a veterinary test? And is it as painful as it is for human testing? Because I might be looking at a change in job descriptions.
No, we totally want to do that. And the test will still need approval for diagnostic use, just like human testing. But from what I can tell, the process is far more straightforward. And hopefully I'm not naive about that. I'll let you know. But yeah, as far as going to vet clinics, when we were trying to get samples, I did go into vet clinics and I was like, hi, can I have you collect some extra blood for this study? And unfortunately, a lot of vet clinics are hesitant to participate because they see it as extra work. And I totally understand that. They're super busy. But now that we have a product kind of almost there, I'm hopeful that veterinarians would be more willing to try it out real time, because now it's not something they need to collect for us. We would, just ask them to test and collect data for us. So I really hope that veterinarians are willing to try. And I'm pretty sure Doug and Tom have recently asked their own vets. But yeah, hopefully they'll help us collect kind of some of that validation data that will be needed for approval. And then we can ultimately just get it approved and improve that turnaround time for diagnostic results in the veterinary world.
That's awesome. I just think it's so neat that you can have one assay and use it for multiple species. So that's great.
Yes, and it's faster than ID, which is 48 hours.
Correct.
Yeah.
Well, thank you both for the insightful discussion. Francisca, it's been an absolute pleasure to have you join us.
Thank you.
And Tom, thank you also for taking time out of your day to talk with us.
Sure. And I'll share one writing tip I have, which is
good.
Please. I should have asked you to begin with.
When you leave it to the last minute, it only takes a minute.
That is not true.
Depends on how fast you type. But seriously, I find if I can, not quite as organized as Alex, but if I can get a couple times, I sort of need to clear an hour, have my tea, it's got to be quiet, get some music on. If I can get an hour and get some thoughts down, then even if I don't come back for a week or two, I've got it cooking up here. And then when I come back, I can and the way I used to write papers in high school, before computers and stuff, I just write a bunch of notes and then cut out all those ideas and then put them all in order and then tape them together. So, it's easier on a computer now, but just like get the ideas on the page and then you can delete it later. But I recall the poster in my high school composition class, which is, so writing's easy. You just stare at the blank page until your forehead bleeds. Which is like, you just got to get the ideas on the page. Once you have something, it feels easier.
That's why I love editing. It's already written.
Editing is my jam.
It is your jam. Well, Alex, I'm, I guess, mentally preparing for next month's topic, which I'm sure will be the latest and greatest AST something or other.
I have two possibilities in mind. One of them is AST and one of them is something else.
Oh, the anticipation.
Stay tuned.
I can't wait. All right. Well, Thank you everyone for listening, and we'll see you next month.